Welcome to this video on anaerobic pneumonia and lung abscess, a clinical primer covering pathogenesis, diagnosis, and management. The essentials of diagnosis often follow an illness script, including aspiration risk, an indolent course, poor oral hygiene, a clinical sign of foul-smelling sputum, and radiographic infiltrate in dependent lung zones. Pathogenesis begins with an aspiration event. While normal microaspiration is cleared, large volume aspiration combined with impaired host defenses leads to infection. Periodontal disease increases the anaerobic bacterial load, contributing to a smoldering clinical timeline, often resulting in tissue necrosis or abscess. Risk factors for aspiration include depressed consciousness from drug or alcohol use, impaired deglutition due to swallowing disorders, and mechanical disruption like intubation. Septic embolization can also cause lung abscesses, independently of aspiration risk. The anatomy of infection is dictated by gravity. In supine aspiration, fluid pools in the posterior segments of the upper lobes and superior segments of the lower lobes. In upright aspiration, fluid pools in the basilar segments of the lower lobes. Anaerobic lung infections are typically polymicrobial, driven by multiple anaerobic species like Prevotella and Fusobacterium. They are often complicated by mixed flora, including facultative anaerobes. A diagnostic challenge is that anaerobes are difficult to recover in culture, especially after antibiotics are given. Clinically, patients present with constitutional symptoms, foul-smelling sputum, and often poor dentition. However, expectorated sputum cultures are unreliable due to contamination. Pleural fluid analysis is the most reliable, high-yield source if empyema is present. Radiographically, anaerobic infections span a spectrum. A lung abscess presents as a thick-walled, solitary cavity with a distinct air fluid level. Necrotizing pneumonia shows multiple smaller cavitations within dense consolidation. Empyema is purulent fluid in the pleural space, often accompanying parenchymal disease. Ultrasound is useful for locating fluid in loculations. The cavitary differential diagnosis is broad. Beyond anaerobic abscess, you must rule out infectious causes like tuberculosis, malignant causes such as carcinoma, vascular issues like pulmonary infarction, and autoimmune/inflammatory conditions like necrobiotic nodules. Pharmacologic management targets anaerobic organisms and facultative anaerobic streptococci. First-line options include beta-lactam/beta-lactamase inhibitors or carbapenems. Second-line options include third-generation cephalosporins, plus metronidazole or a fluoroquinolone. Treatment is prolonged, continuing until the abscess cavity completely resolves on imaging. Procedural management requires a crucial distinction. Empyema, located in the pleural space, requires tube thoracostomy drainage. However, a peripheral lung abscess, located in the parenchyma, should not have a chest tube placed, as this risks a catastrophic bronchopleural fistula. Medical management is the mainstay. Thoracic surgery consultation is reserved for complications or failures, such as exceptionally large abscesses or catastrophic rupture into the pleural space. Surgical options include percutaneous drainage, segmentectomy, lobectomy, or pneumonectomy. In summary, anaerobic pneumonia and lung abscess involve patients with aspiration risk and poor dentition. They occur in dependent lung zones due to polymicrobial anaerobes. Diagnosis relies on indolent symptoms and imaging showing cavities or empyema. Management involves prolonged antibiotics and careful procedural intervention. Drain empyemas, but never place a chest tube into a lung abscess. This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.